Welcome back to the podcast. In this episode, I'm going to be speaking with Geoff Healey around thoracic trauma. So in the episode, we really want to explore the challenges of assessing and treating various patients with thoracic injuries such as pneumothorax, haemothorax, and flail chest. But we fundamentally want to do this in the pre-hospital environment. So we're going to discuss the primary and secondary survey. We're also going to discuss airway management considerations with thoracic trauma. And we're also going to examine and explore the efficacy and evolution of some of the modern interventions that have evolved over time, such as needle chest decompression. We're also going to examine some real-life cases just to illustrate the complexities of thoracic trauma in pre-hospital care. So to do this, I have Geoff Healey with me. Geoff is a Prehospital and Retrieval Physician with Sydney HEMS. He's also a Consultant Anaesthetist at Royal North Shore Hospital in Sydney, and indeed now the Director of Trauma. He is also the Deputy Medical Manager for Sydney HEMS. He's also got extensive experience both within Australia's pre-hospital and retrieval system, but also within the UK and London's air ambulance. He is an active New South Wales Taskforce Urban Search and Rescue team member and has been deployed overseas for various humanitarian missions. Geoff, welcome to the podcast.
Thank you very much for having me.
It's great to see you again, mate. I just wonder if we could start, Geoff, by just exploring some of, from your perspective and indeed your experience, Geoff, and what you see in contemporary practice, some of the most common causes of thoracic trauma in pre-hospital care.
So I think you can probably break it down quite simply into blunt trauma and then penetrating trauma. In the UK, there's a lot more penetrating trauma than I would suggest we have in Sydney, but and it's access to knives and guns and all that sort of stuff. And I think that framework works quite nicely because I think the diseases are quite different. So a blunt thoracic injury often has a slightly different pattern of injury that you'd expect. And we see this with high-speed motor vehicle accidents, pedestrians hit by cars, bicycles, and an ever-emerging group of patients, which is the e-scooter rider. In addition to that, we also get a separate age group, which is predominantly the older patient which gets thoracic trauma from falls. And these can be simple falls from height or falls downstairs. And with sort of the aging process and the osteoporotic process that goes on in their bones, they tend to get quite significant multiple rib fractures or flail chest type sort of injuries. In the penetrating trauma group, this is again a different pathological group. I think if you think about it quite separately, they often have discrete tracks or variable tracks of injury throughout the chest. And it can injure everything from all the way from skin, subcutaneous tissue through ribs into both the lungs, but also mediastinal contents and the spine. And I think when you think about the thoracic cavity, everyone tends to think about ribs and lungs, but it's really important we don't forget the mediastinum and the spine. And we've certainly had a number of patients that have had a gunshot wound injury to the chest, and that the bullets lodged in the spinal canal, and they have significant disease processes with neurological components of shock as well as the hypovolemic type sort of stuff. So whenever I think about it, I separate that into those two groups.
Yeah, that's fascinating, actually. And like you said, there can be a real mixed pathology. It was something we'll talk about later. Just around. Not when you're assessing the chest, not forgetting the back of the chest,
Yeah.
which is commonly missed, and this is the pathology toward in and of the spine and the spinal canal is often forgotten as part of maybe a chest assessment, and it's really interesting to speak about that. Geoff, one of the really big challenges of pre-hospital care, and me and you've both worked together in London and seen it before, is just the sequelae and indeed the initial stages of chest pathology or chest or thoracic trauma, which hasn't presented yet because you are so early on in the disease process. It can be an evolving pathology. Could you maybe speak to the challenges of the primary and secondary assessments when suspecting thoracic trauma, and indeed sequelae that hasn't maybe presented yet? What's your sort of index of suspicion got to be like in prehospital care?
Yeah, this is a great question because it's really, really hard, and it's really hard to teach. And I've supervised registrars and consultants coming into pre-hospital care and watch their assessments, and I find this also very difficult. I think there's a couple of things that are hurdles to begin with. First of all, the chest needs to be exposed. You need to be actually able to see the whole chest and the back, which you've mentioned just in the last point. And that can be difficult. And I think there's a big gender difference. We tend to not expose female chests as much as we do male chests, naturally because of dignity and all that sort of stuff. And the modalities that we have are limited. And so the old concept of look, listen, feel, I think most people don't tend to spend enough time looking at the chest or looking at the back is the first thing, because you can see paradoxical breathing and flail segments and all sorts of seesaw breathing. But sometimes that's missed because we feel as though that's not as valuable a part of the assessment. Listening in the pre-hospital environment, I think I haven't used a stethoscope for probably about 20 years, and I'm probably industrially deaf from working around helicopters. But I just don't feel breath sounds in my workplace is very useful. But I know that I have ultrasound and other tools that the other EMS and first responders may not have. And so listening can be very difficult, and it can be very challenging to try and work out what you're listening for. A decreased breath sounds could be a pneumothorax, but it also could be just a non-aerated functioning lung underneath with full of pulmonary contusions. And when you complete out the look, listen, feel by feeling the chest, I think we probably don't give it the respect that we need to sometimes when we do a quick March assessment. And actually feel for individual ribs, feel for the sternum, feel for the clavicles, have a look in the armpits, and give that full sense of what's going on in terms of rib fractures. I think the process to go to a secondary sort of assessment, we tend to use in our system ultrasound. But again, ultrasound doesn't necessarily always give you the full picture. And we can always be led down the stray of seeing a lack of lung sliding sign on ultrasound and go, well, we need to intervene in this person's chest, when we may not actually need to. Not all pneumothoraces need to be drained. And then the other thing to realize is that, again, like I said before, it's not only the lungs that are inside the chest. There are major vessels and obviously the heart of the chest. And you and I have certainly been on jobs together where a patient's bled their whole entire blood volume into their chest. And this is one of the most complex, non-compressible type hemorrhages that you can see. And if you see them early on in the disease process, you might actually see them when they've still got some physiology and they've still got a pulse. But by the next 5-10 minutes, they may have exsanguinated into that hidden cavity. And it's extremely hard to rule that out initially on your initial survey. So these can be really nuanced patients. And to, I suppose, make a point for this podcast, I think you need to pay respect to the chest when you do your examination.
Yeah. Absolutely. I think that's an absolute fundamental point, actually. And your point about exposure is absolutely key, because I archetypally and historically would very much suffer from that issue around exposure and just making sure there's that systematic exposure. Geoff, just looking at differentiation between different types of thoracic injuries. Again, I guess in a way this kind of leads back to question 2, but how much are you worried about or not the differentiation of a pneumothorax versus a haemothorax versus a flail chest in the early stages of injury?
This is something that I've been thinking about for a long time, and we're often taught very early on that a pneumothorax needs to be drained, the blood needs to get out of the chest. A flail chest will destroy all lung ventilation. But in actual fact, the longer I do this job and the longer I look after these patients in hospital, I find that actually you don't need to intervene in all of these different diagnoses, and the actual diagnosis can be impossible to make without CT sometimes. I've seen people use ultrasound and say there's lung sliding signs, there's no lung point, and they still have a pneumothorax. I've seen people put drains in that haven't drained anything else, and they've got a significant haemothorax. And I've seen people with flail chests managed in the hospital system on paracetamol or acetaminophen only. And then I've seen others that have a thoracic epidural. So they're not a homogenous group. They're not all exactly the same. They're all very, very different. And so part of that is how we assess these patients, but also how they respond to the things we do. And the assessment of the various different types of injuries, I think, is extremely hard and nuanced. I think one of the things that we get led astray with when we're taught how to do this sort of stuff is we look for things like tracheal deviation, and we look for gross deformity. But in actual fact, I think a lot of these sorts of things are incredibly late signs. I think pain is a very sensitive thing if you've got a conscious interacting patient, but sometimes they're not. They're confused or they're hypoxic and they won't be able to localize where the injuries are. I think one of the major big bang for your buck examination finding is subcutaneous emphysema. Subcutaneous emphysema is absolutely barn door that there's some communication with the lung and the tissue around the chest, and that makes a massive difference for anything you subsequently do. It means there's high enough pressure that there's air getting into a tissue plane and a potential space. And that means you need to treat this person, the injuries of the chest with respect. And of course, once you see subcutaneous emphysema, then ultrasound's completely out of the game. It doesn't make a difference because you can't see anything underneath it. I think you need to pay attention to the physiology and what's going on with the rest of their systems. People talk about spontaneous tension pneumothoraces and stuff all the time, and we do see it very, very occasionally, but it's almost like a unicorn disease process. I think once you start positive pressure ventilating these sorts of patients, I think that's when you start to uncover things. And I also say that, it's different for different ages. If you're a pediatric patient, they rarely ever have bony injuries, and a lot of that soft cartilaginous bone transmit all of the injury onto the actual underlying lung tissue. And we've seen that with large sort of case series of pediatric patients being hit by cars. They can often have quite significant chest injuries and significant hypoxemia without any actual clinical signs in the chest at all. And so I think we're trying to, especially as EMS or first responders, pre-hospital medical teams, we're trying to get a sense of what's happening on the inside of the chest with findings of the outside of the chest. And so it's extremely difficult, I think, unless we've got some of the modalities like ultrasound or CT. And so I think you have to have a healthy suspicion when you've got hard signs of chest injury. If they've got an obvious deformity, they've obviously got subcutaneous emphysema, then that requires some sort of treatment and intervention.
So, Geoff, just pivoting and looking at airway management and how you manage an airway with someone with thoracic trauma, either, like you said before, positive pressure ventilation or otherwise. I guess the generic question is, what's top of mind when managing an airway? I guess it might be easier to separate these into sort of ventilated and non-ventilated patients. But if you could maybe give us top of mind from both a ventilated and non-ventilated patient when a patient does have significant thoracic trauma.
Yeah, I think as an anaesthetist, I've obviously got a little bit of a biased sort of approach to this sort of process, but because obviously within the thoracic cavity is the ventilation process and mechanic, the normal ventilation process is going on in our patients, that can be significantly hampered by significant thoracic trauma. And so that goes from everything from pulmonary contusions to affecting ventilation perfusion mismatch, to diaphragmatic injuries, to bleeding, to pressures outside of the lung causing it to collapse, as well as direct sort of tracheobronchial tree injuries where there's not actually air going into the lung anymore. And so there's a fantastic book that I teach all of the critical care paramedics when they first come to aeromedical in Sydney called Respiratory Physiology, The Essentials by John West. And it's about 80 pages, and it's a fantastic book. It's sometimes hard to read, but one of the key things it talks about for the causes of hypoxemia is not everything responds to increased FiO2 oxygen. We have to really have a concept of the fact that of the four causes of hypoxemia, hyperventilation really only is the one that responds to giving extra oxygen. And this is something that's been taught in EMS school for millennia, is that everyone that's hypoxic, you give them oxygen that gets better, but doesn't. And VQ mismatch, where there's a lung that's being ventilated, that's not being ventilated, but it's getting blood, means that there'll be blood coming back to the left side of the heart that hasn't been oxygenated, and you'll get a reduced mixed venous gas. And so these are the sort of patients that might need to have decompression of their chest and then positive pressure ventilation with PEEP to be able to re-oxygenate them. And so that may not necessarily need to be intubated. I think a group of these patients might be really useful just to have a good sitting mask over their mouth with a PEEP valve on a BVM and try and give them supported pressure support type sort of breaths. If you're going to intubate these patients, they often are very difficult to pre-oxygenate, and they might drop like a rock as soon as you stop them breathing or make them apneic. And so all of those things that we try and do, like a bit of non-invasive ventilation or ventilation with PEEP beforehand, apneic diffusion oxygenation and doing RSIs with appropriate doses of drugs and whatever else, I think are really important to be able to maximize that safe apnea time, and then being ready to do an intervention afterwards if they drop off their perch. There is absolutely no doubt that positive pressure ventilation affects venous return into the chest. And so if you're hypovolemic for any cause, for multi-compartment multi-trauma, I think that's one of the biggest insults that can befit our patients in this sort of stage. So we were very early in the last couple of decades to talk about this concept of resuscitate before you intubate. So they need to get some circulating blood volume back, and plug the holes in the bucket before you're going to be positive pressure ventilating them. So from a non-ventilating point of view, I think it's if you've got a decompression as part of your skill set, that might be worthwhile. It might be worthwhile considering positive pressure ventilation with PEEP to try and bring that lung back up, and then respecting the airway for the patient that needs to be intubated to make sure that there's not circulatory embarrassment as well as respiratory embarrassment during the airway process.
So, Geoff, let's just look at some of the other interventions which have, I guess, in a way, undergone significant evolution. That would be needle chest decompression with armored needles, and sort of more, I guess, the initial phases of pleural drainage with armored needles. Could I get your perspective and thoughts on improvements in needle chest decompression and the sort of the efficacy of these interventions?
I apologize in advance for your listeners, but this is one of my massive rants that I go on, and this is obviously on the bias of seeing the patients that come into the emergency department that we admit under the trauma service in my hospital. And also, I'm biased because I'm on the clinical practice committee of our ambulance service, New South Wales ambulance service. So I see both sides of the story. And the rant is that I think needle decompression devices can be life-saving in certain conditions. There is absolutely no doubt in my mind. However, I would say 2/3 or more never get into the chest. And that's even with the newer ones that come out. I've got more than 50 plus x-rays of chest decompression devices that are not in the chest. I've had paramedic crews talk to me and swear blindly that they heard a hiss and that the needle has never gone into the thorax. It's sitting in a subcutaneous plane, and they may very well have got a hiss because there was subcutaneous emphysema under tension in that tissue plane, and it's probably decompressed subcutaneous emphysema. I've got basically a case series of so many of these that I don't think we even have a feel of how unsuccessful they are, both nationally and internationally. And I really can't see much difference between the longer ones and the older, shorter ones. Maybe the longer ones probably a little bit increased hit rate. And there's a couple of things that I think are the reason for this. One is we teach this as a rare skill that's often done by crews that don't do it very often, and they never get a hard point of knowing whether they're in the right spot or not. and that is a massive failing of the system. Whenever I get an ambulance crew, paramedics put these in, I get them to come back into ED after we've done a chest X-ray or a CT, and I get them to re-look at their landmarks and look and see whether the needle's in the chest or not, because that's the only feedback you properly get to see whether these have done their job or not. And they may very well have been in the chest for a short period of time, but if they're out of the thorax by the time they come into hospital, that's fine, as long as they get some feedback. So I would encourage every one of your podcast listeners to do this with every patient they put a needle in the chest. It is unexcusable to not see whether it was in the right spot or not, because you'll never get any feedback or learn whether it was the right place to do it or not. I've seen everything from the first to the sixth intercostal space having needles in it. I've seen people doing it in the mid-axillary line, and I've also seen and heard of case reports of patients that have had them in the SVC or IVC junction. We've had patients have them in the subclavian veins right under the clavicle, and we've had a 12-gauge dwell cath in a pediatric patient in Sydney in the last 10 years go into the left ventricle. So these are extremely dangerous procedures, and we don't actually teach our crews very well. We don't govern them very well. And we don't give them the feedback of whether they were in the right spot or not. To not completely blanket it and say it's negative, when they are done, they are life-saving. They will remove the circulatory embarrassment of a tension pneumothorax, but they won't do anything else. They won't bring the lung back up, and they won't stay patent for very long. And so I think it's really important that we understand that it's a limited device purely as a last-ditch type of thing to treat tension pneumothorax, but it does absolutely nothing else. It does nothing to the underlying lung, and it certainly won't be for the rest of this patient's clinical journey.
I think that's fascinating, actually, Geoff, and some real lessons to be learned there. I'm just looking and pivoting and looking at open chest wounds or indeed sucking chest wounds in the pre-hospital environment. I mean, after 20 years and indeed over 10 years of critical care practice, I myself can't remember seeing a sucking chest wound, and it does get in sort of the hierarchy of time through teaching courses. It seems to get a lot of attention for pathology, which is so rare. But could I get you to maybe speak to how you manage open chest wounds and indeed sucking chest wounds, and indeed whether you see it frequently within practice or not?
Yeah. So in my current practice at the moment, we're not a very high penetrating penetrating trauma country. So I think predominantly most of these sucking chest wounds are caused by penetrating injury. I have seen a couple in my experience over the years, maybe less than 5, and they can be challenging to manage. And I agree that there's an abnormal amount of time spent dealing with this in teaching and other processes for almost a unicorn disease process. Like, it's so rare, but we spend so much time teaching stuff about it. And in addition to that, there's like 1,000 different things on the market, dressing wise, that go for these sorts of injuries, which usually tells you that none of them actually work. And so for the few that I've seen, a 3-sided dressing or some of these commercially available devices, there was even one that had a Heimlich valve built into the wall of it. All of them do nothing to treating the pathology. I think it's a complete and utter waste of time. My approach to open chest wounds would be very similar to any severe chest wound without an opening or with massive tracheobronchial leak. And my approach would be a good, thorough assessment. I wouldn't put anything through a forensic wound. So we teach that in our system, to not instrument forensic wounds, because that's important from a forensic follow-up point of view. If they're in severe pain, give them analgesia. If they're in our setting, they'd probably get an RSI, and then they'd get that wound dressed and have a separate clean thoracostomy, and they'd be managed that way with positive pressure ventilation and PEEP. If you work in a system that doesn't have RSI, what I would suggest most people do is give this patient adequate pain relief, keep it in perspective of any of the other injuries that this patient may have. But I would leave that wound completely open and I would give them supported breaths with a BVM and a PEEP. And that's the only way that underlying lung would potentially come back up and you'd be able to reoxygenate the patient. If they're oxygenating fine, I'd leave them well alone. I think that's probably the best thing. Apart from getting blood spurted in your face and having all your proper PPE on, I wouldn't get too fixated on a sucking chest wound either. I just don't think that they're such a massive disease process that we see all the time. It's just so rare.
So, Geoff, just some of your questions before, or indeed your answers before, were hugely interesting around you recognize pathology. It doesn't mean you need to intervene in the pathology, and I think that's a key message, really. But one of the aspects is there is potential complications with thoracic trauma, and just to link into your point, actually, you can actually complicate chest pathology by being over interventional. I think sometimes by being maybe too aggressive when a patient is managing themselves. But could you maybe speak to some of the complications you've seen in practice and how you manage them?
Yeah. So look, the whole spectrum of complications can come from thoracic trauma. So prolonged hypoxia because of some sort of embarrassment of the respiratory system. Any intervention into the chest obviously is into a sterile place, and you can get infection, empyema, and a whole bunch of other things. Long-term complications with dysfunctional pain syndromes associated with big flail chest injuries. We see that quite a lot with people that have poorly managed pain from flail chests and other injuries. There are non-union injuries associated with rib fractures that come into hospital, and these can affect ventilation long term. There are other things, like I said before, that are in the chest other than the lungs. So pulmonary contusions a big problem in terms of ventilation, and they can be very hard to manage afterwards. But also things like mediastinal trauma, mediastinal hematomas, direct cardiac injury. They can have arrhythmias and a whole bunch of other things associated with a direct blow to the heart. We've seen people that have significant flail chests and sternal fractures. One of the spinal surgeons in our institution talks about, we know very much about three-column injuries being unstable in the thoracic spine, which is the anterior, posterior, and ligamentum flavum type sort of segments of the spine. But if you fracture your sternum as well as your thoracic spine, that's a four-column injury, and that means it's highly unstable. There's nothing holding that sort of upper section of the body connected to the spine. And so the sternal fracture needs to be treated with respect and is a real complication in terms of fixation or whether they're able to handle a brace if it's being treated conservatively. And the outlet of the thoracic cavity is really important as well. So all the great vessels that come out underneath the clavicles, going down the arms, the brachial plexus coming out of the neck above the thorax, all these sorts of things are potential complications if we either intervene inappropriately or we miss things in the chest. And so, and obviously the final potential complication of thoracic trauma is obviously death. And so some of these things we can intervene in, and some of them, like a transected aortic route from a severe blunt deceleration type sort of trauma injury, like a motorcycle injury. Some of these are almost universally fatal. So we have to understand sometimes we just can't treat all of the complications that happen sometimes in the chest.
So, Geoff, just looking at thoracic trauma in the sense of more formal pleural drainage, such as finger thoracostomy or chest tube placement, certainly when we were working in London, we definitely saw a higher rate of formal pleural drainage through thoracostomy rather than chest tube placement. And I think in a way, the adage of prehospital care is that you are going through such a ambulatory phase of care. So you're moving patients through multiple environments, multiple care transitions sometimes, or a singular. But and that doesn't necessarily give way to smooth passage of a formal chest tube, which has the capacity to move. Could I get you to speak to what you see the preferences in Australia, and does it mimic London? Is this a high rate of formal finger thoracostomy versus chest tube in the pre-hospital environment? How does that look?
This is probably what I'd say is probably a G up. This is my next rant that I could probably go on for hours about.
Yeah.
So, Look, again, this is my opinion and this is my cognitive bias, having worked in the UK system and being one of the managers of the Sydney system. And it's not universal across all the pre-hospital care organisations around the world. But my feeling is very much that if we're going to intervene in the chest, we're doing a surgical procedure, the treatment is a finger thoracostomy, and that is not instrumented until they get to hospital. And the reason for this is multiple. First of all, we're doing a sterile procedure in a non-sterile fashion. And we know that there is weak evidence, but there is evidence in the literature that there is still an empire rate from putting a chest tube into a sterile environment that is greater than putting your finger in. The second thing is chest tubes are incredibly complex to put in, and they are the last bastion of a trauma system that is decades old, where they used to put a large bore chest drain in everyone that had chest trauma. And when I was a very junior doctor, we would put in 30 or 40 chest drains as a junior doctor into patients in our first few years of medical practice. And that was before CT, the days of readily accessible CT. And now I would suggest that some of the advanced trainees in critical care barely put in half a dozen in their whole training. And so it's a procedure that's almost disappeared from practice, because a lot of the interventions don't need to be done and they don't need large bore chest drain access. So it's rarer. Even the cardiothoracic surgeons that do large numbers of chest drains put most of their drains from the inside of the chest to the outside of the chest and not the other way around. We know from the literature that chest drains have a very high complication rate, and it's about 30 to 35%. And this ranges from everything from malplacement, just doesn't go in the chest, to empyema, intrathoracic injury from being put into the wrong spot, or it just doesn't do its job. And if a tube is not doing its job, the only way to know whether it's not doing its job in the pre-hospital environment is to pull it out. If we've got the cognitive bias that we've treated the chest and we've put a chest tube in and we don't go back and see whether it's the problem, we will miss the deadly complication of a blocked tube. And there is absolutely nothing that is used in the pre-hospital environment worldwide for the chest drain connecting set that would resemble what we do in hospital, which is a formal underwater seal drain. And so all of the other stuff really is MacGyvering up with Heimlich valves or ridiculous plastic Portex bags that do not emulate what actually you need to have connected to the chest drain, which is an underwater seal drain. No service that I'm aware of in the world uses underwater seal drains once they put them in. And so my feeling is that with positive pressure ventilation, an anaesthetized patient and a hole in the chest, that is completely and utterly fine and all that needs to be done. And if they become respiratory or cardiovascularly embarrassed, they get a refinger of their thoracostomy, and everything else can be done in hospital. The next controversy, but it's probably not too important to talk about, but whether when you're in hospital, whether you put a tube through that thoracostomy or when you arrive or make another formal hole. And my feeling is that if it's clean and it's not overtly contaminated from the outside, I think it's fine to put a tube through that hole. But if you're concerned, making another hole and putting a clean tube in as a sterile procedure is perfectly fine. And I know some institutions do that. The only other thing is we teach a different way of doing finger thoracostomies to formal chest drain insertion in our service. And I think it's really important for the practitioner to know that we teach a instrument-based procedure with blunt dissection of the intercostal muscles to prevent people putting their fingers through that hole and getting a bone stick injury. And our bone stick injury rates have dropped significantly from teaching that sort of method. And it doesn't damage the underlying lung. So it's a blunt technique. It dissects, it has a reduced retention rate, And when it's done properly, it's completely and utterly fine. The healing rates and the infection wound rates of them are very, very, very low. So I think it's a very safe procedure when done properly, and I think it's the best thing in terms of complications downstream.
So just looking at your approach, Geoff, to pain management in thoracic trauma and indeed fluid resuscitation, one of the old adages in my paramedic training, and it wasn't controversial, but there was an evolution of practice around giving patients morphine with chest injuries just to actually ease the pain, and as you said, actually ease the ability to maintain a respiratory rate which was sufficient for the patient, but in very much small aliquots, and just to facilitate a patient's own pain management. I think very much the fear was giving opiates. I think from a medical director perspective, in a large ambulance service, giving opiates to a patient which is self-ventilating with chest pathology. Could you maybe speak to, and like you said, this podcast serves paramedics, doctors, nurses, and otherwise, but could you speak to giving opiates to chest injuries, and indeed your thoughts on pain management, and indeed fluid resuscitation for thoracic trauma?
Yeah, so again, this is a topic close to my heart, pardon the pun, with thoracic trauma, because I'm an anaesthetist and I have been involved in acute pain management for these sorts of patients for many years. And so I have a reasonably structured approach to chest injuries, being mindful of the fact that it's really important to know what type of pain they have. So the first concept is the structures that are obviously innervated, that are really important to think about in terms of what injuries they have, are obviously the skin and subcutaneous type sort of areas, but the periosteum of the bone of ribs can be exquisitely painful. And what patients will naturally do is that they will reduce their tidal volume breaths to stop the fracture sort of lines moving against each other and causing crepitus and pain. And so that can cause them to hyperventilate significantly. And we know that when we give them analgesia, a paradoxical thing happens is that they're able to then subsequently take bigger breaths and their respiratory embarrassment disappears. And so I'm well aware of the fact that they used to say, and they used to teach, don't give opiates to these people because they're already respiratory impaired. But in actual fact, the opposite occurs. They actually can take bigger breaths and they oxygenate much better. And we see that with various different multitudes of modalities, which I'll talk about in a minute. The other thing is obviously important, really, really important, is how we package these patients and we manage them and positioning them. If they've got an isolated chest injury, they will almost always do better postured upright. But if they're a multi-trauma patient, then obviously we can't always do that. And so we just have to be mindful about clot preservation packaging, how we move them, how we winch them, how we carry them, and how we move them out of the environments they are from an extrication point of view. And it's humane to give them analgesia before we move them, because I've seen patients that have been inadequately analgesed absolutely screaming like a banshee when you move them. It's just inhumane. And so I look at things from an analgesia point of view from probably a multitude of different ways. First of all, it's opiates. And I think morphine's perfectly fine. I think fentanyl's rapid acting and short duration and can be handled quite well by patients. Obviously, you have to be careful that if you give a rapid bolus of fentanyl, they sometimes have a little bit of a sort of deer in the headlights, rapid pupillary dilation and an apneic phase from just a large bolus of fentanyl. But small aliquots of fentanyl can be quite good, and often the opiates can give them the ability to be able to take a bigger tidal volume breath. In patients that have very suspect circulation or they've got hypovolemic shock from other reasons, I think ketamine is a really good option with less sympathetic ablation and as part of a sort of well-balanced package of care proceeding to RSI. I think ketamine as a sole agent or in combination with opiates, I think is very good. The next group is, depending on the workflow and the nature of the job and how long we might be transporting these, we're doing an increased number of ultrasound-guided serratus anterior blocks. And so this is a reasonably straightforward block for the groups of people that work pre-hospitally that are able to do this and have ultrasound to be able to do it. We've seen patients with flail chests have quite significant improvements in analgesia to the point where that might last 6 to 8 hours. And I think that's a real massive advent in the pre-hospital system, is the ability to be able to do some regional blocks. Again, it's obviously dependent on the system. And so I think with any analgesic requirement, having a dose and having a therapeutic index of where you're aiming for and then redosing them to make them comfortable is an important thing. So obviously you don't just get them there and forget about it. You'll have to keep them in that therapeutic range. And again, looking, I can talk for hours about fluid resuscitation in chest injuries. I'd just say that I'd probably give almost none of these patients crystalloids anymore. If they need circulating volume, or if I'm worried about venous return into the heart, I'd remove the obstruction in the chest and I'd give them blood products, and that's almost universal. I think these days that's a no-brainer.
So just coming into land slightly, Geoff, just a couple more questions.
Yeah.
Just one would be around, like you said, it's absolutely fascinating working in London, because you do see a high rate of penetrating trauma, certainly from a stabbing and indeed a ballistic perspective as well. But could you maybe speak to if there's a memorable case that you could maybe recall for us that you learned a lot from, either from the case itself or indeed in D&D or in M&M, or some sort of debrief, and because you have mentioned so many salient points and indeed learning lessons, is there a similar case that sort of sticks in mind that you garnered a lot of learning from?
Again, I'm aware of time. I've got 3 cases that I think are really important learning points. One was a patient, and it's a reasonably famous patient in Australia, that had a case report written up in one of the journals. She was an elephant handler in the zoo, and she got pushed up against the fence of the enclosure by a young bull elephant and got crushed and had an asphyxial traumatic cardiac arrest. And she was extremely well managed by the paramedic crews who basically got her alive to hospital, but was peri-arrest. And she had some of the most impressive subcutaneous emphysema I've ever seen in my entire life. It went from basically her forehead all the way down her legs and through both arms. And she arrived being bag valve mask ventilated. She didn't have any IV access because they couldn't get any essence of where her veins were because of the subcutaneous emphysema. And she was significantly obtunded from her hypoxia. And the lessons from this case was, first of all, to not get distracted by, something that's spectacular in its first appearance and just do your basic type sort of stuff. She needed, obviously, to have some IV access, get some analgesia and some ketamine on board, and be intubated and ventilated appropriately. She needed to have her chest decompressed, and she needed to have some sort of plan of what was going to be happening next. So her IV access was extremely difficult. No ultrasound was able to be used because she had so much subcutaneous air, so it was just blanked out. And so we managed to get some IV access in her legs, but also one of the older physicians did a venous cut down, which was probably the only time I'd ever suggest a venous cut down would be useful in this sort of modern day and age. And so we were able to get venous access, which was very difficult. The second thing was the finger thoracostomies on this patient were extremely difficult because there was so much air through the tissue planes. It was hard to identify whether they were in the chest or not when they were doing the finger thoracostomies. And immediately upon decompression of her chest, a lot of her physiology looked dramatically better. She looked much pinker from a pale peri-arrest type sort of process. And she had a blood pressure again. She could feel peripheral pulses, and she was able to be oxygenated from that point. And then the airway management, once the tube was in, everything seemed to settle down. And there was a large argument within the physicians that were all present whether we needed to go immediately upstairs and do a thoracotomy for this patient, when in actual fact she didn't need any more treatment other than cardiothoracic intensive care, and to let her fractures be managed in her chest and the subcutaneous air to be distributed and then reabsorbed. And that's all the treatment she needed for her chest injuries, nothing else. So doing a thoracotomy on this patient, I think, would have been a disaster. And so that was the one of the three patients. The second patient that really stands in my mind was a patient that was a motorcyclist who hit a bollard at about 140, 150 kilometers per hour. And forgive me, I don't know what that is in miles per hour, but it's bloody fast. And they completely and utterly caved in their chest. But it must have been in part of the respiratory cycle where they had a full tidal volume in their lungs, and they had a significant and massive tracheobronchial injury. And so to the point where there was a open chest injury where when they were being ventilated, almost the whole BVM volume would come out the wall of the chest. And so for those that are interested in physiology, if you've got a hole in the tracheobronchial tree that's over half the size of the trachea, then air obviously will preferentially go out through that hole and not into the rest of the lungs and expand the lungs because they're so elastic and have a sort of a compliance type sort of process. So this person was unable to be ventilated externally. And so they got an RSI and they got a package with finger thoracostomies and blood resuscitation. But when they got to hospital, they needed to have either one lung ventilation or multiple chest drains in that side of the chest to reduce the diameter of the hole coming out of the chest to preferentially fill up the lungs. And this patient was so difficult to ventilate and had such severe chest injuries. There was contemplation of ECMO and a whole bunch of other things. And so that was a lesson that I learned about preferential one lung ventilation and how you'd manage massive tracheobronchial free injuries. And the last one, very quickly, is my first thoracotomy. And again, for those that are in the system that have this as part of their skill set, this is something that you'll remember for the rest of your entire clinical career. I remember the time of day. I remember the music that was playing on the radio in the house that I went into. I remember who was there. I remember who was supervising me, and I remember the outcome. And this is stuff that will stay with you for the rest of your career. And I've taught and I've debriefed probably, maybe 30 or 40 clinicians that have done a thoracotomy as their first one and debrief them after they've done it. And they all say exactly the same thing. It's such a memorable event, such a high complexity intervention to do that it will stay with you forever. So chest injuries are a group of injuries that are incredibly complex. They're very nuanced, and they will stay with you throughout your whole career.
Listen, that's powerful, Geoff. And to your point, actually, remember my first thoracotomy, and it is, I think, such a visceral experience that, like you said, I can go straight back there, and it's what now 15 years ago, but I straight back there, and it is because like you said, it's so otherly. There's so much stuff which is going on, which is in practice it's such a shift, and it is so visceral from a intervention perspective. And I can't think of any other intervention which is so revealing and indeed exposing to the patient, and yeah, it absolutely stays with me.
100%. It's an absolute privilege to open up someone's cavity and do internal cardiac massage on someone that you're trying to honorably do an intervention to save their life. I agree with you. It is so confronting that it is just something that stays with you forever.
So just a couple more questions. One would be, Geoff, around just to your mind, are there any empirical studies at the moment ongoing around thoracic trauma, or indeed, the efficacy of intervention, the preference of intervention? So just almost baseline data around audits. Is there anything going on down under that's in thoracic trauma which is of interest?
I don't really have a lot of visibility on a great deal of pre-hospital studies. I think there are lots of poor quality papers out there about intercostal catheters versus finger thoracostomies and all that sort of stuff. And a lot of it is based on on audit type sort of level data. So I don't think it's very great. I think what is interesting from an in-hospital perspective is rib fixation surgery on these sorts of patients, and currently there's large groups of um, sort of prospective and retrospective data that show there's probably equipoise. There's probably no difference of whether we put plates and screws in these ribs or not. But I think there'll be emerging evidence over the next few years that if you've got significantly displaced fractures and you're not able to be weaned off a ventilator, then getting early rib fixation is going to make a massive difference. And so that then goes back to all the other things we do pre-hospitally. If you're doing finger thoracostomies or you're putting dirty tubes into chests, they're at increased risk of empyema rate, and then they can get infected plates. So I think we have to be careful about our interventions if we think about the downstream stuff that's going to happen in hospital. So that's the first thing. The second thing is I think there's an increasing emergence on endoluminal and hybrid type techniques in hospital resuscitation. And I think that the rates of thoracotomies are going to be much smaller for in hospital major vessel type sort of injuries. So they're able to treat thoracic aortic injuries much easier from an endoluminal point of view, and even subclavian vessel injuries, rather than having massive cuts and going onto bypass and doing a lot of stuff, which is obviously complex and requires lots of intervention. And so I think, like a lot of things, we will see advancements in those ways of treating things through that combined hybrid endoluminal and open type approach to thoracic trauma in hospital.
Yes, that's fantastic. Absolutely fantastic. So just to finish off, really, it just for listeners, is there any salient learning points or indeed just salient take-home messages, Geoff, that you just like to leave people as top of mind when dealing with thoracic trauma?
Yeah, I think in summary of all the stuff we've talked about today, I think chest injuries are nuanced and can be difficult to assess. And I think there are some soft signs that can be missed and hard signs that shouldn't be missed, like subcutaneous emphysema. But it pays respect to spending a bit of time listening and feeling and examining the chest thoroughly. I think it's important to realize that increased inspired oxygen doesn't cure all respiratory embarrassment, and that if you've got a lung down, it doesn't necessarily need to be intervened every single time. But lungs don't just come up if you put a needle in it. They actually need to be ventilated, mechanically ventilated, or have a tube with a underwater seal and suction for it to actually re-expand. They won't re-expand unless you do something about it. And I think we need to focus on doing the basics well for these sorts of patients. And I know this is very much a Gareth Davies type sort of stuff. All the fancy stuff in the world doesn't make a difference if you don't do the basics really, really well. And I think one of the things we miss with respiratory embarrassment is actually giving a trial of ventilation, trying with some positive pressure ventilation and some PEEP, and seeing if we can manage these unicorn diseases like sucking chest wounds and all that sort of stuff without relying on fancy dressings and other things that I don't think probably makes too much of a difference. And I think the last point is something I probably said earlier on, is that it's not just the lungs that are in your chest. There are some massive other structures in there that are important, like the heart, the mediastinal contents, great vessels, and of course the spinal cord and vertebral column. And so they all go through the thoracic cavity, and they're all an important part of your assessment to make assessment of what's actually going to kill your patients in front of you.
Yeah, listen, that's a great place to finish, and it's great just to wrap up with those learning points. Just leaves me to thank you, mate, for the last hour, because it's fantastic reconnecting with you, but also just getting some of your pearls of wisdom. So thank you.
Thank you very much, and it's fantastic to be able to chat to you about this sort of stuff. Being mindful of the fact, obviously, I'm a bit biased and controversial about some of my opinions, but it's based on what we see regularly and making a positive change to the system to make sure we do the best by our patients.
Absolutely.